pleasure, we're going to do probably 4 or 5 sessions on trauma. So I don't know what level you are all at. I am tasked to try and get you through an AMC exam, and that's what I've been asked to do. And that means I'm trying to put you into a situation that if you are confronted with trauma, which I'm told by Athol is a difficult concept for you in your exams, that you can make a meaningful answer. So if we go to the next slide, Athol, this is going to go over about 3 or 4 sessions. There are about 300 slides. It is not death by PowerPoint. We're going to do them in 4 and enough sessions to get you through what you would need to do, A, to understand what happens in trauma, B, to look at what happens to each organ system, C, how to deal with the intricacies of each one, D, to put a trauma system in practice and where you'd fit as an intern, and lastly, we'll take a real patient on a journey. So that's what we're planning to do in this set of lectures. So this is what we've got. Basic concepts of trauma response. We're going to start with what the heck the organism does. That'll be tonight. Then we're going to look at management priorities. We're going to interweave that with each of the above. I'm going to talk about a primary and secondary survey and give you a system on a slide that it works. And hint, it's exactly the same as the system we use for our Sick Patient 101, except it's a more truncated version up front for trauma. We're going to look at how to resuscitate, monitor, and lastly, we're going to look at how the rest of the patient's thing is going to give us some clues. So next slide. Next slide. Here we are. So that's what we're going to do. Let's go. Next slide.
Bit slow.
That's all right. Okay, go back one slide. This will be, in the end, what we are going to have as our patient. You're going to have pictures of everything for this particular patient as we get to the last part of this talk. We will take a 21-year-old male with the following traumas. Hardly anything, and there's hardly any rocket science in this. But by the time we get to him, you'll be able to know what we do, why we do it, and how we do it in the way it is done. And we'll go from there. So if we go to the next slide, I don't know what you know by way of your level of training to this point. So I'm going to assume you are university students who have little knowledge of or appreciation of or even care much about some underlying basic pathophysiology, but we need to know it for trauma. So next slide. Oops, slide before. Very, very twitchy tonight.
Very twitchy.
Okay, so this is the concept of trauma. There are a limited number of ways your body is going to respond. As we'll come to within each organ, we're going to break that down as well. It's a recurring theme. We did this for the sick patient one, if you remember. Once we understand that, we will see there's a limited number of ways the host, i.e. our patient, is going to react. Further to that, and this is where trauma systems become vital, once we reach break point, you're in this now for the next 2 weeks. So the whole aim of a trauma system is to stop the individual getting to a point where the organ fails, because once it fails, there is no comeback until it regenerates over a fixed period. The next thing to remind ourselves is, as we journey through the ward and our patient at the end, we will take on a ward journey as well. You must expect the process to change. Up front, trauma is conceptually dead easy. You stop the bleeding and you fill the bucket. Pretty easy. However, the knock-on effect of that is a cytokine release. Therefore, in a ward setting, you will expect an inflammatory process, and hence you have to reconsider your 0 points looking after a patient in a ward setting. And we will dwell on that as well when we come to it. The last bit of that slide is crucial. Edema is highly inefficient. It is an incredibly energy-dense method to produce adequate oxygen delivery. Hence, what we have to do is minimize tissue damage, because once this process occurs, we have a high oxygen need, high oxygen use, incredibly inefficient system trying to maintain everything. And that's what we're going to dwell on tonight, is what your body does and how it gets there. Next slide. At a global level, you have a hierarchy of needs. The way to think about trauma, and indeed all forms of shock, is you will do anything to keep your heart-brain axis alive. Anything. You will jettison every other organ. And indeed, if you're sick enough in ICU, we will deliberately jettison organs to do that. So it's not uncommon for us to deliberately jettison kidneys to maintain dry lungs, to maintain oxygen to other organs that need it. Your body will do that itself. It'll accomplish this by some predictable things. Those of you who know a little bit about endocrinology, you will retain salt and water and you will pump out a whole lot of catecholamines. So the body will reliably fail. It will jettison splanchnic circulation first, limbs second, and lastly, brain, because its pump system fails, heart and lungs. Within each organ, we're going to have a hierarchy of failure as well. Next slide. So we came to this last when we did the sick patient. That little thing in blue down the bottom is your resuscitation goal. You do not need to know what the Latin means. I'll explain it to you. DO2 was oxygen delivery. Oxygen delivery is nothing more than cardiac output by hemoglobin, by conversion factor to convert hemoglobin in gram percent into something we can use for our equation, multiplied by oxygen sats. That is the formula of life to deliver oxygen, full stop. Nothing else we do matters. That's it. Bugger all of any oxygen we dissolve in the blood matters at all, 0.003 times PaO2. It is only, PaO2 is only useful to you as a means of telling you what the sats should be. Hence, a pulse oximeter is all we need. We do not need to ever know the partial pressure of oxygen in our arterial blood. The sats on that formula is what matters. That formula is the formula of life, as we call it. There are two ways, therefore, to sustain your organism. One is to make that go up, and the second is to decrease VO2 or oxygen use. And the role of a trauma system is to maximize the first without breaking it, and secondly, minimize the second. And by minimizing the second in trauma, this will be things like pain relief, splintage, putting in a catheter for pain. All of those trite, simple things you do also decrease extraneous oxygen use, meaning your heart and lungs do not have to work that hard. Next slide. We're getting to the next slide.
I'm trying hard.
Oh, there we are. This is much the same, if you look at it, as what we did when we talked about the critically ill patient. There are two ways we can deliver adequate oxygen to an end organ. One, we can make the heart and lungs work harder, or secondly, we can decrease the amount of oxygen the organs need by decreasing extraneous work by them. So things like analgesia and sedation used properly work. Temperature control works. If you're too hot, you increase your metabolic rate. If you're too cold, you don't clot and your heart doesn't work. Nutrition is vital for two reasons. One is we need substrate for the heart and lungs to work, but secondly, we also need to protect the gut from getting stress ulcers. Delirium is important, and this for you when you become junior doctors is critical. One episode of delirium lasting 5 days or more in hospital has a 60% 1-year mortality. Doesn't matter how you get it, ladies and gentlemen. So consequently, things like a sleep-wake cycle, things like getting people up and exercising them, etc., work. Benzodiazepines do not work. Likewise, avoidance of inappropriate drug withdrawal. So if someone's normally on narcotics, we keep them on their narcotics. That is important. Next slide. So the trauma system, as I said, to harp on this, we maximize oxygen delivery in a way which is consuming the least amount of oxygen itself. And we minimize the extraneous oxygen needs. Okay, so next slide. The concept, as I said, the organism will do everything it can to deliver as much oxygen as my internet. It says my internet thing is unstable. It's gone again, so whatever. The organism will do all it can to maintain oxygen delivery. Once a breakpoint is reached for each organ, it will fail, and it will fail reliably. Next slide. This comes to this concept of apoptosis. Does everyone know what apoptosis is? That's right, it's okay, you can go to the next slide. For those of you who don't, you can think of it as programmed cell death, i.e. we reach a breakpoint, the organism will fail, and it will fail by jettisoning things that it doesn't need first. The best example would be the use of a Glasgow Coma Score. A Glasgow Coma Score has 3 components: eyes, motor, and voice. Voice is the one that is the most sensitive because it consumes vastly the most amount of oxygen. It requires a frontal lobe. It requires you to consider your answer, and it requires you to formulate it using muscles. However, you don't need it to stay alive. Nobody cares. So you will breathe, you will keep your eyes open, you will move, but you will lose voice earliest. And we can do that for each organ. For example, moving on. Next slide. Okay, go back one. This lends itself with, if we look at it, and you don't need to know these slides, this is some background. What it lends itself to is if you look down on the left, or dysfunction score, you will see we have organs there. The Denver score uses lungs, kidneys, heart, and liver. SOFA score uses lungs, bone marrow, liver, heart, kidneys, and CNS, and MOD's the same. What they do is they go from grade 1, grade 0 to grade 4, and basically the sicker you are, you will see the organ fails. And it fails in the most energy-dense way it can. If, for example, we take lungs, we see that you need more oxygen because lungs leak. Kidneys, liver, bilirubin goes up. Kidneys, creatinine goes up because you lose your ability to excrete or clear creatinine. You basically can't filter it. Hearts go from needing fluid to needing inotropes to needing vasopressors, etc. Next slide. This is the model that you probably, or you will come across as residence. It's called the SOFA score. In fact, you can use a QSOFA or a QAD score. It's the same thing. And pretty much all they do is take that and reduce it to a "are you sick" number. But I point out at the bottom of this, all of these scores have been validated for trauma with the anatomical-based retrospective scoring system. So any multimodal, physiologically based scoring system will work to tell you A, how sick you are, and B, your risk of death. Consequently, we're going to look at what's available to us simply in trauma. Next slide. This is a quick SOFA score. Next slide, and this is the one in the wards that you will see in some of your hospitals. Next slide. This now becomes, nope, go back one. This now becomes what we have for trauma. If you look at what you can do at the roadside, instead of using numbers, but rather use what you know as normal results, you can see that you can take the oxygen delivery system, that is respirate, because you don't have anything else to look at the roadside, cardiovascular parameters, and really all you care about immediately is a map, but pulse pressure, as we saw before, will tell us about the type of shock we have, and end organs, which we're going to use urine and coma score, and indeed we can even use skin, with point of care testing for base excess to help us. This is what we can use immediately and has been validated against those other systems. Next slide. So what we can appreciate is that we have tables that confirm our apoptotic concept, that an organ will fail reliably if we stress it enough. Since that, we can now model what we expect to see per organ. Next slide. And that's what we're going to see per organ, ladies and gentlemen. Brain, you're going to get an encephalopathy. Now, you will call it sundowning, delirium, abnormal coma score, depending on whatever craft you're doing in a ward. But basically, you'll knock off the voice component of a coma score. Hearts, you will get a stiff ventricle, hence the only way around this is to increase your heart rate, then eventually get troponin leak, which indicates that you have increased heart rate and some edematous cardiac muscle, and lastly, arrhythmias. Lungs need a shed load of oxygen to keep gas on one side, blood on the other, across a membrane of cells. Consequently, pulmonary edema we see in every form of trauma. You break your ankle today, I will guarantee you your AA gradient is up tomorrow because of the inflammatory response. Livers get a coagulopathy and eventually a cholestasis. Kidneys, ATN, so you lose your ability to concentrate urine, then you lose your ability to make any urine. Gastric mucosa, highly energy needed to keep the mucosa free from being eroded by the acid. So you get stress ulcers. In the bowel, we get ileus because we need blood to make the bowel move. And eventually we're going to put bacteria, because if we think about bowel, all it is a dialysis membrane. The bacteria on one side of the lumen and blood on the other. Skin and muscle, well, we're going to get pallor simply because we don't deliver any blood there. Then we're going to get loss of thermal regulation. Then we're going to get pressure areas and eventually dead and then reperfused compartment syndromes as they become edematous. And blood, we're going to knock off eventually all three cell lines, thrombocytopenia being first, then red cells and eventually white cells. You see, I put something there called the leukoerythroblastic response. When you reperfuse, you'll get a leukemoid reaction, and all that means is the marrow will chuck out anything it can and their primitive cells. So we see that our organs will reliably fail in a reliable way. That is all the basis of all of these trauma systems or scoring systems physiologically are. Now, next slide. The concept, therefore, allows you to assess how bad the problem is and where the problem is, because if something is further along that decay line, it is very likely that organ is affected more than the rest, or was affected more than the rest before we got here. So let's take, for example, our diabetic patient who already has bad kidneys. It's very obvious that their renal function is going to fail much earlier than a normal clean skin having the same trauma. So once we accept this concept that organs will fail reliably, we, from a schematic table, can determine where on this they are, and also if one is out of whack, that is either the one that is chronically affected first or most, or is the one that our major problem is? Next. Do feel free to ask questions if you get there. These are more fun if you're interactive. Okay, so whoops, there. So adequate substrate. Well, causes in trauma, everyone thinks of bleeding, and, you know, bless their cotton socks, I'm not a surgeon. We like surgeons, by and large. They stop bleeding, drain pus and go away. So from an intensive care point of view, they're simple little creatures who do good things. However, we have to think a little bit more laterally in trauma, because whilst bleeding is most common and will accentuate all the others, I want you to turn your mind to how you might get obstructive shock. Anyone answer? Now, I don't know how many people we've got looking, so I'll have to just blindly ask. I've got OUM meetings and I've got no one there. So Carolyn, you get a question because I can see your name. What do you reckon might cause obstructive shock?
I've never heard of obstructive shock as a type of shock.
What forms of shock do you know, Carolyn?
Oh, septic shock,
Sorry.
cardiogenic shock, so pump failure.
Good, pump failure, I like that, well done.
Anaphylactic shock.
Okay, yep.
Yeah, stuff like that. Obstructive.
Okay,
So what would be obstructed and cause shock?
So the way I think of it, I think of shock in two ways. Have you got access to my first lecture of how I think of shock?
Yeah.
You think of it, shock only comes in two forms, Carolyn, hot and cold. So we're not going to be dealing with hot shock here. We've got until we're later with sepsis. You got cold shock to start with. Cold shock's easy. There's either nothing in the pipe, the pump doesn't work, which is what you've said, or the pump's blocked. That's it. So bleeding's easy. All right. You look at the patient, can't see a JVP, they've got a narrow pulse pressure and they're cold. Pump failure is easy, they bubble and they're cold. Obstructive shock and trauma, either the blood can't get in, and someone's quite rightly put that up on the chat, or the blood can't get out. And we don't often have PEs up front. So it's usually blood can't get in. Now in trauma, what two things might stop the blood getting into the chest?
Oh, it's all kind of clotted. The trauma that's interrupted the feed of blood back to the heart through clotting.
Well, how about we put a lot of clot around the heart and don't let it fill? Would that cause it? If it can't fill, because we block it in its pericardium with trauma, we get a tamponade.
So edema, the pericardial.
Well, there's one. Or how about we put so much air in the chest outside a lung that we now have more intrathoracic pressure because we've got a one-way valve. We call it a tension. No, not pneumothorax. What sort of
hemothorax?
No, not quite. Tension.
Tension pneumothorax. Yeah.
Because what you've got is a one-way valve. So you've got their obstructive shock without blood loss necessarily. Okay, 50 mils of blood in your pericardium will do that. So you don't need a lot of blood loss to get obstructive shock. It's just where the choke point is. And this is why with trauma, well, the choke point in the system, isn't it? We've got to get blood out, blood back and blood out, don't we? We think about it. Now, if we then come to warm shock, which is the last two, burns is really not trauma. I don't think of burns as trauma. Burns is nothing more than pancreatitis that you can see. You have a huge cytokine release and you leak like a bloody sieve. That's burns. You add trauma to it. If you think about it in that way, the management of burns makes so much more sense. Because what you've done is basically taken an organism, damaged every bit of tissue you can find in that burned bit, and it will leak like a sieve. So instead of pancreatitis and things that you've seen, I like that, break the barrier is very good. Thelma, terrific idea. You can see it. And sepsis from infection is late, but it's the same thing. You leak. So trauma is going to give us all of these. We all think of bleeding, and of course we focus on it because it's simple. But in reality, we have to often think, yes, but. And as we'll come to, we can see all forms of shock. If you want to add to that, let's chop your spinal cord just for fun, and you're going to have neurogenic shock, aren't you? So whilst we talk about shock and trauma is always bleeding, we have to always keep our mind open to the others. Burns is a terrific example of a chemically mediated leaking system. Think of it like pancreatitis, and pancreatitis is really just sterile sepsis. That's really what it is. And this is the same in that sense. All right, next slide.
Doesn't seem to like waiting.
There we are. However, because we do like surgeons and trauma is pattern recognition, that's where you bleed from. Okay? So blood on the floor and 4 more. So external is blood on the floor, obviously. Pelvis is the hidden one. Femurs, you have one closed femur. It's about a litre and a bit. Chest, you can lose anywhere up to 1.5 litres in a chest for a massive hemothorax. Abdomen, you can lose litres. Now, the important thing here is that our trauma or our primary survey will therefore focus on chest and pelvis because we can't see them. So that's your first 2 x-rays that'll go into your system when you see our system. Femurs are usually pretty obvious. Rule of thumb, if the fracture's compound, double the amount of blood loss you expect is a pretty reasonable rule of thumb. So 2 fractured femurs is 3+ litres. Oh, sorry, 2 closed femurs is 2 and a bit litres, 2 fractured is 3+ litres if they're compound. So we really need to think about how much blood we can lose. And we'll look at that a bit later. All right, next. Oxygen delivery, we come back to this time and again. This is what our system is there to do. Now, we dwell on this a little bit, and you look at sites of bleeding, you can see that the easiest way to improve C is going to be to reduce bleeding, isn't it? Which is why we're going to have splints, compression onto limbs, pelvic binders, all of which will decrease the space and potential space into which we bleed. That's a far better way of doing it, giving old, cold, stiff red cells or acid, which is basically resuscitation fluid. All right, next. Okay, so getting back to this, cardiac output, and we'll come to this in a bit later, is the key. Hemoglobin is the key, and SATs. Right, suffice to say 8 is what we aim for in a chronic patient. You're bleeding, we don't want you to get under 8, so we start blood early, and when we see our trauma systems, you'll see after the second bolus, we are thinking of introducing a massive transfusion protocol, of which there are many, but basically they're all balanced there, 1:1:1 of red cells, platelets, and coagulation product. The SATs are all that matters. You can't, unless you're in a hyperbaric chamber, do much once the SATs are over about 92. Next slide. So this is my life. I will explain it to you in simple terms for you. Preload for you is how much blood is coming back to the heart. That is the simple way to think about it. The definition you don't need to worry about. It is how much blood you are putting into the cylinder called a ventricle. That'll do. Contractility is how quickly it can squeeze together. And afterload for you is what you're pumping out against. That is the simple way to think about it. They are broad concepts of formulae, but that will do for what you need. So what you have to optimize in our patient is optimizing blood coming back into the cylinder. It is not, how quickly can we get ABO? What is ABO, Marky? Makey, I don't know what you mean by ABO.
Oh, sorry, just the blood typing. So how you mentioned,
we just give you, we give O negative flat. You'll have 2 units up front. We'll get type specific blood in 20 minutes where I work. I don't know for you, but we can have type specific in 20 minutes, but you'll just run O negative. Yeah, O negative for trauma, that's right. Okay, and the rest of it doesn't matter. Platelets don't discriminate and the coagulation products are easy. So we'll dwell a bit on that when we come to hematology, but it's a good question. But the important thing for you to always remember is not how much blood is available to come back to the heart, it's got to get there, which means we have to look at what's in our chest, which makes the chest X-ray early on vital. Then how well we squeeze, that's not usually a problem. Your heart operates at about 95% of its capacity, sitting here doing nothing at the moment. Probably Carolyn's is a little higher at the moment because I asked her a question and it's probably closer to 100, but most of us, the contractility is pretty good. The afterload in trauma will go up because you squeeze. And that is not good for our patients with parlous hearts. One of the reasons we need to give them adequate volume is to decrease the work the heart's got to do, obviously, doesn't it? Okay, next slide. So, heart rate and stroke volume. Ladies and gentlemen, heart rate, is it a very good way or bad way to increase your cardiac output? What do you think, Marky?
I'm not too sure I understand.
Well, there are 2 ways to double your cardiac output, Makey. You can either increase your heart rate or increase your stroke volume. And I'll give you a hint, athletes don't have a high heart rate, do they?
No.
Which one, therefore, do you think is more efficient? Low and full. Much more efficient. And I'll walk you through why. Does your heart fill in systole or diastole? Diastole, doesn't it? The ventricle. Okay. Is systole or diastole a fixed period? Which one is a fixed period pretty much no matter what your heart rate is?
I would say systole.
Well, it's a fixed period, which means if I double your heart rate, I must decrease the diastolic filling time. It's shorter, isn't it? Yep. Yes, it has to be. Now, I therefore am relying on 1, adequate volume, but 2 now, if I decrease that time, when you fill your ventricle in diastole, do you fill it passively or do you rely a lot on the atria to ram that blood in? Which one? Anyone can answer.
I think the passive filling's the main thing.
Terrific, well done. Okay, passive filling, about 80% of your filling is passive. If I increase your rate, you become atrially dependent. Hence, the atrial component increases and increases and increases. Its work, it's not got much muscle and it fails early, and hence you get your atrial fibrillation and all falls apart. That is the apoptotic effect on a heart. We've just done it. That's why they get arrhythmias. Okay, so we want to keep someone, if we're looking at this, with a good stroke volume and the minimum heart rate to do it. It's the most efficient way to deliver the oxygen. Okay, next slide, therefore. Okie dokie. Yep, Carolyn's right. If you pump too fast, you are inefficient. You're quite right. No, slide back. Okay, sorry, next slide. Athol, you flicked and flicked, sorry. It's finicky tonight, isn't it? There we are. So here is your cardiac output, heart rate and stroke volume. And as you can see, they will eventually become coupled. Because if I increase my heart rate enough, my stroke volume goes down, doesn't it? So this is not a magic bullet system. The reason we can use heart rate early in our system is that it becomes a nice, easy surrogate marker because it will reliably go up. This peripheral vascular, it'll only be helpful to a point, Anne, and the point will be until it consumes more oxygen than it has. You will then get atrial fibrillation. Your cardiac output will in fact go down because your left ventricle will be filled less and you'll be using increased rate for decreased output. So in that sense, it's not a magic game at all. There is a fairly fixed point, and for adults, it's somewhere around about 140, 150. You're not going to get any cardiac output above that, and that's in reasonably young people. The older you get, the lower that is. So next slide. There we are. Here's a schematic of what we have to get back in and what we have to pump out. You can see we can think of a heart at the moment as two separate pumps in series. The low pressure one gets blood back from the body, pumps it through the lungs, where oxygen and CO2 swap, goes to the left side, and we're going to pump it back to all of the other organs. That's pretty much what we can think of. Now, next slide. Catecholamines initially are going to squeeze the venous side. And that makes sense. Initially, we're going to try and increase the volume coming back, aren't we, to the heart without necessarily ramming up the rate because there's nothing in the system. It makes sense. So our early, not much blood loss form of shock, we're going to have no JVP, and we're going to have a heart rate rise, but everything else is pretty much okay. You could think about giving a bag of blood, the blood bank. Someone's going to pull out from you, say 500 mils of blood. You get up and you walk out. The reason you can do that is we'll squeeze your venous side and happy days. Next slide. As our shock gets worse, we start to see the failing organs in our shock table. So we get pale skin. We get renal impairment. Urine output goes down and eventually kidneys fail. We get an ileus of our gut and other organ systems, bone marrow and liver will drop out. Right to the end, we will keep our brain going because it is what is going to try and keep us alive with our heart-lung complex. But eventually it too will fail. If you burn about 40% of your blood volume, your coma score will reliably be about 9 or 10. Eventually it will fail. Next slide. This, for you, I'll walk you through. It is not, I don't know how much physiology you do, so I'm going to try and walk you through. Do you do physiology? I don't know. So can someone help me? Yes? Are you familiar with what that is? Or is it an, oh my God, please don't ask me, but I'll nod anyway?
We
Carolyn's
do
laughing.
we do physiology, but I don't recognize
Yes.
these acronyms immediately,
Ah.
or this, or I do. I recognize the kind of some of the arrows. Yeah.
Yeah.
And but please walk us through it, because I'm sure you'll do a fabulous job.
I see Thelma's cardiac output has gone up right now. She said, okay, this is the determinants of stroke volume put graphically. You're familiar with the Frank-Starling curve? This is Otto Frank's determinant of stroke volume. Starling's curve is an amalgam of these. If we take the blue line, that is preload. What it says is, as we stretch the fibre because we fill the cylinder, eventually, you see volume on the bottom side, eventually it will be filled to such a point the pressure will eventually go up. At some point, isoelectrically, remember your little ECG? That little muscle will go, oops, I best contract. And you will get isovolumic muscle twitch. That is the upgoing arrow. And where it then tapers off is when the aortic valve opens in the left ventricle. And you will push blood out until you get to the green line, or after the load you pump out against, in which case you can't pump anymore and it will relax. The efficiency at which that pumps out is determined by the crimson line, or contractility. That's all those three curves are. And it forms an area under that curve, which is stroke volume. And from that, we are now going to model what happens with hemorrhage. Next slide. The one on the left is what you know as the Starling curve. It makes no sense at all until you understand that its real value lies, if you reverse that, it is the bottom curve on Otto Frank's determinant. Because what Ernst Starling said in 1916 was the volume in the cylinder causing the stretch in the fibre determined how much we could pump out. That's what he said. The reason you have three curves there is the curve above and the curve below are determined by the addition of increasing or decreasing afterload and contractility, which is why when you see those multiple curves of the Starling curve and you go, my God, I can't make sense of them. In fact, what they try to do in one curve is what we're seeing on the right-hand side of that diagram, which are the three components. Now, look what happens to the stroke volume that was in the dotted area if I merely just don't like somebody and chop off their arm and look at the amount of blood loss. The volume coming back to the heart diminishes, doesn't it? Afterload goes up. We know that because we get cold limbs, don't we? You see, contractility doesn't change much because it's already fairly fixed, and our stroke volume goes down immensely. Thus, unless we do something to increase the volume in the system, the only way we can maintain our cardiac output is to increase our rate, which causes enormous oxygen use. Next slide. Now, I'm going to give you the break point. That is the curve on the right. Eventually, when your ventricle gets very stiff and edematous, it can't fill very well because it is very stiff, and hence I can't put as much volume in because it's all swollen as a concept. And this is end-stage cold shock with troponin leak, atrial fibrillation, and everything else. What we have is a stiff, almost cardiogenic type heart. And that's the end of its apoptotic response. It has now failed. So our job is to intervene when it's all on the same filling curve, because we have a chance of minimizing the ongoing problem. No doubt, if you bleed 40% of your blood volume today, go to theatre tonight, tomorrow your heart is not going to be flash if we echo it, but it is not going to be like the heart on the right. It is still retrievable. It's going to have an inflammatory response. It's going to have a fairly rough time. It's going to have a bit of atrial fibrillation, but it is going to survive. The one on the right, there is no combination there besides heart-lung bypass that buys you anything for that heart. That's the problem. So, next slide. Trauma produces this cascade. The initial response is we turn out a very high resistance system. We have to. It will try initially to ram blood back by squeezing the venous side, and then will squeeze everything else it can to get blood back on the venous side. And will need an incredibly high heart rate and eventually will kill itself. Next slide. Which lends us now to this. No, back. There. This is the generic hemorrhagic table. If you look at it, reliably at the roadside, it says heart rate will go up with volume loss. 15% of your volume is something around 750 mils, 30% 750 to about 1500 to 2 litres. More than 2 litres is the percentage in an adult. Heart rate goes up. Notice blood pressure doesn't change much. And the reason for that is as your pulse pressure goes down, your diastolic pressure initially goes up because you squeeze, don't you? So your map doesn't change because your map is diastolic pressure plus a third the difference. So if initially I squeeze it up, even though the top number doesn't change, we see therefore initially blood pressure is a terrible marker of shock. Your blood pressure, you've got to lose a lot of blood before you'll actually drop your blood pressure. Pulse pressure is a little more sensitive. Your respiratory rate will reliably go up and your urine output reliably down, and coma score reliably down, and base excess, which we talked about before, we talked about last time, is another nice marker. Down the bottom there is the need for blood, predictable. Next slide. This is actually well validated for you. ILCOR looked at it in 2015, and we can add base excess to it. So we go to the next slide. Base excess we talked about last time. Back one. Back one slide, Ethel. There we are. Trauma is terrific for the use of base excess. If you think about it, as we said last time, there are really only 3 causes in your world as surgeons that you're going to have to worry about. One is lactate, one is ketones, and one is chloride. Well, not many of our patients are going to be DKA, are they? So in trauma, it becomes lactate and chloride as to how much fluid you need to keep them there. Next slide. Which means you now have a system as well, not only looking at your patient's observations, and we'll do this when we come to our target patient that we're going to walk through this whole process with you at the end, but also you have base excess via point of care testing to help you as well. And that utility is also well validated. So you have an apoptotic table, which I've shown you hopefully over these slides, is based in physiology and has validity when we compare it to the numbers we would use when we hand at the bedside or the roadside. Next. Okay. The role, therefore, of resuscitation is to increase stroke volume and minimize the extraneous heart rate. Volume, therefore, is the key. 10 to 20 mils of crystalloid, as long as it's wet, warm, and balanced, it doesn't matter what you use. Okay, it's pretty simple. The one caveat here I would say is if you thought of a crush syndrome, which is we'll come to when we do that, you probably don't want to use potassium. It's a bit silly because you're going to get a shed load when you release it. But pretty much if you use crystalloid, wet, warm, and balanced is fine. Repeat by 1 and then give blood. A fairly reasonable recipe. Okay, next. Now we've talked about how we're going to pump the stuff. We better talk about how we're going to get some oxygen into it. And we did this last time, so we're going to refresh our memory so you guys don't have to do revision for your exams. Now, all of you are terrifically gifted in respiratory physiology, I know, because I know my residents just adore talking about it. So I won't ask you too many questions. We'll just sort of skim by and I might just give you some highlights because I know you'll know the rest. Does that sound fair? Otherwise, do you want me to ask you questions? Would that be easier, Thelma? I'm teasing, it's all right.
No, that's
Okay.
fine.
I'm teasing. All right, next slide. This is what you're trying to deliver. For those of you who don't know it, it is called an oxygen dissociation curve. And basically all it is it says hemoglobin will reliably give up oxygen in a curve like that fashion. It will also shift and give up more or less oxygen depending on other things. And those other things are temperature, carbon dioxide, 2,3-DPG, you probably all learnt this list in physiology. All 2,3-DPG is phosphate. Where does phosphate live? Inside, yes, or outside the cell? No. There's a hint here, guys. So if your phosphate is up, you must have mushed a lot of tissue. Pretty simple. So if you think about it, anything that is going to cause you to be so damaged that you're going to get mushed tissue, you're going to try and give up oxygen, aren't you, to the end organ. And that's pretty much that curve. If you think about it that way, that is that curve. Shift to the right, let's see, I'm going to drop your pH. Well, if you've got lactate, I'm going to give more oxygen to end organ. That makes sense, doesn't it? Or I'm going to give you a lot of chloride. Well, that makes sense. So it makes sense we give a bit of chloride there because we're going to give up more oxygen to our end organs. CO2 going up. Well, if I'm not breathing well, I'll probably try and give up oxygen to the tissue, so that's okay. Temperature. Yep, if my temperature's up, I've usually got sepsis, so it's probably a good idea to give oxygen to tissues. And lastly, I've got a lot of dead muscle. So pretty much those things that move the curve to give up oxygen are pretty easy to remember. Is it going to hurt you? Yep, well, it'll probably be something that'll move the curve. That's all you need to know for your exam. For practical purposes, all you need to know is the saturation. Look at the top of that curve. Once you hit about 92, you can give a shed load of oxygen and you ain't going to get much more bang for your buck. So we look at the SATs, which means you, in the acute phase, do not need an arterial blood gas, as we talked about. That is why the venous blood gas works. You put a little thing on their finger, and I got to tell you, if your SATs say 90%, your PaO2 is about 60, or about 3 million years of evolution's wrong. And I'm either saying either your PaO2 is not 60 or 3 million years of evolution's wrong. I think we'll go on the fact that it's 60. So you do not need acutely an arterial blood gas. All you need is an oximeter. A The blood gas is to tell you the other things, the base excess and the CO2. This reinforces all we talked about a fortnight ago. That's why I said to you in an award setting a fortnight ago, you do not need an arterial blood gas. It doesn't matter to you. Okay, next slide. What you do need to realise is some basics. And pretty much there is the big formula, P big AO2, is the amount of oxygen in an alveolus. Since you breathe 21% oxygen, there is no other way but to increase your minute volume, which is your respiratory rate, as a surrogate to drop your CO2, to increase the amount of oxygen you can put into your blood. There is no other way to do it. And that's why respiratory rate is incredibly sensitive for a sick patient. Even putting a mask on someone doesn't give you that much oxygen. We can do that in a whole other talk. So it is why respiratory rate goes up. It is all you have. So once we know that, let's go down to the next slide. As I said, no need to dwell on it. We've had our separate lecture. Next slide. And here is the comparison I gave you of venous and arterial last time. For your purposes, a venous gas is fine and fine for trauma. You see the base excess is reliable for what you need. The oxygen sats you don't care about, you have an oximeter. pH is relatively the same for what you need, 7.35, 7.45, it's not that much different. O2 you don't need. CO2 is reliably about 5 higher. So we did this last time. For your purposes, a venous gas is going to tell you everything you need for trauma. Next slide. This, however, is what trauma does to you. This is you breathing at the moment, sitting up. We think about this conceptually. You have a water pump in the middle of your chest. We call it the heart. It's trying to pump red stuff through the lungs and back to the heart and out to the body. Water does not pump well uphill. Hence, at the top of your lungs, normally you have what we call dead space. It is ventilated, but it is not well perfused. And as Carolyn quite rightly pointed out before to us, if we have obstructive shock, we're going to make dead space worse because it is ventilated and not perfused. I'll give you an X-ray example of that in a little while. Zone 2 is Goldilocks, because water flows. From zone 3, water flows better downhill, but we're compressing lung. Now think what happens with trauma. Next slide. This conceptually is you at the moment. Maybe your CO2 is a little lower because you think I'm going to ask you a question, but apart from that, it's you guys at the moment. Blood comes in at about stats of 75, goes out at about 95 to 100. Now, next slide. Since CO2 has a very limited, CO2, I don't know where you all live, so I'll use the thing I use down here. Some of the students we teach go to Griffith University, others go to Bond. Both can come up with this concept. What bubbles through water or alcohol is CO2. CO2 bubbles quite happily through fluid. Oxygen does not. Once we realise that concept, we realise that the venous gas you did for trauma will give you a terrific marker of ventilation via the CO2. Because if it's high, either centrally they're not breathing at all, or it can't get out. because it's not pumping enough blood to the area. Next slide. Here is what will happen in all trauma. You break your ankle tonight, that area that says 75 and 75 will be the effect of trauma. What you will do is have edema in your lungs because they will leak. Your respiratory rate will go up slightly. Your CO2 will be normal. However, your AA gradient will go up because you have edematous membranes. Oxygen can't get in. What would happen if we gave you oxygen? Next slide. Is very little if that edema is more than 30% of your lung. You're quite right. It is a VQ mismatch, Thelma. We call it a shunt, but you're quite right. A VQ mismatch can either be shunt or dead space, but it's a VQ mismatch. You're quite right. This is one of the reasons we give a lot of oxygen to trauma, because we know that they don't do well because of trauma anywhere. They very poorly respond to oxygen, and that's part of the reason. Their lungs will leak. Next slide. Turn your mind to the fact, however, that if I have decreased venous return, I am now, how different would it if we had a CO2 retainer? Not at all. Not at all. They will try and breathe their CO2 out. Their numbers will still be higher. They will fail earlier, but their response will be the same. One of the worst things you can do is deprive someone who's a CO2 retainer of oxygen when they're acutely unwell. When they're acutely unwell, all of the thoracic societies say, give them oxygen. So that one's a fairly simple acute statement, and then you wind backwards. In the case, however, of trauma, and I have decreased venous return, that dead space we talked about normally will increase because I'm not going to pump as much blood uphill. Now, normally dead space is not a bad issue, which is why the CO2 retainers aren't a big problem. If we go to the next slide, in general, and this is your COAD patient, give them a bit of oxygen, they're fine. They need almost no oxygen because basically whatever blood gets there to those under-perfused areas will oxygenate up quite well. So the trauma patient gets the worst of both worlds. They will get edema normally. That is part of their response. If we inadequately resuscitate them, they will have increased dead space, so they get the worst of both worlds. A pathological increase in dead space and a pathological increase in shunt, which is why we give them a lot of oxygen early and can wind back. Next slide. So the apoptotic effect of trauma anywhere in the body is to give these people pulmonary infiltrates. It is part of the apoptotic response. We add to that an inadequate cardiac output, then we add to this a pathological dead space, and that becomes a nightmare scenario because we are at the same time increasing a respiratory rate, which is inefficient to oxygen delivery to the bottom end, and at the same time, am not delivering enough blood to the very area that it could help, which would be your dead space area. So we need adequate resuscitation, and that is what we do in trauma. Next slide. But, and this is the big but, we don't give limitless fluid, because if we do, and you already have an inflammatory leaking process, we make the shunt worse. So how do we determine adequacy? We use our shock cable. We use our reducing respiratory rate. We use serial x-rays over hours to days, but usually you get one at admission, one after theatre, one the next day, and we use our serial gases. That's what we do, and we do not deprive them of oxygen in the interim. So what you've got at the bedside is respiratory rate, point of care gases, and an X-ray. That's what we have. Next slide. Right, so let's think now of some X-ray. Let's think of some chest injuries and see how we can make this worse. Hypoxia, hypoventilation, acidosis. All right, now let's see. Hypoxia, we've talked about, we're going to give oxygen, but we're now going to have to think if our patient's hypoxic, aren't we? Have we got adequate venous return? I give you an example of profound hypoxia. Someone has a massive pulmonary embolus, they're hypoxic. The treatment is not to give them more oxygen or ventilate them. The answer is warm. Room temperature is good. In the ideal world, we do warm everything to body temperature, simply because hearts hate being cold. Once your temperature's under 35.5, you don't clot, your heart hates it. It's one of the reasons when people come off bypass and we do hearts, we always warm them up. So good question. Hypoventilation is bad from our alveolar gas equation. Acidosis is bad. Hearts hate it. Respiratory acidosis tells us, as we've seen with your comments, we have a patient who is failing. Every patient who has trauma should have, at worst, a low normal CO2. If it is high normal, this doesn't fit having pain. It does not fit having any significant trauma, does it? So you have to go and look for the cause. Next slide. Oh, here we are. Here's one I prepared earlier for you, ladies and gentlemen. So let's think and look at this. Why might this patient be hypoxic? And I'm not going to discriminate. Everyone can come up with an answer because you'll always be right here. So, Makey, away you go. Go early, girl, because you'll get the easy question here.
So looking at the X-ray, what do I see?
Mm-hmm.
So I see, is it perhaps pleural fluid in the right lung?
I think that's terrific. So, in my very simple way of looking at chest X-rays, and we'll do a whole section on chest X-rays, there are only three things can give you white in a lung: red cells, white cells, or water. If you think about it, there's no other option, or no black, which is no air. They're your only choices. So here, if we look at the right side, it's white, isn't it? Correct? So it's trauma. What might cause white in trauma? Red cells, white cells, or water?
So blood or water?
Blood or water. Terrific answer. Most likely blood up front here because it's unilateral, but a very sensible answer. I like that. Well done. All right. Not good enough now, Carolyn. What else might be problems here in this chest X-ray?
The dark black on the left.
Yep.
So some pneumothorax, tension pneumothorax, maybe pushing in.
I know what you mean. The answer to that is
I don't know.
no,
Just looks.
the lines go all the
No,
way to the
you can
outside.
actually see. Yeah, you can see the lung markings.
Yeah. What can you see outside the chest, Carolyn? Where's black where it shouldn't be? You normally have black outside the rib cage. Have a look at the rib cage down the left chest and down the right chest. Is there normally black there? That's
yes.
right. Whoever said
Yeah.
that. Yeah. What do you call that?
Yeah,
Huh?
someone's written it. Yeah. Oh, I think you
Terrific.
spelt it wrong. Subcuations.
Oh, that's all right. She did a very good
Subcutaneous
answer.
emphysema. Thank
Oh,
you.
all right, now, I want you to tease this out for me now, Carolyn. If you get that, what must the lung be like underneath that?
Well, it's leaking air out through the chest wall.
Right. So do you reckon this lung is good or damaged?
No, this is not a
Terrific.
good
So
lung.
what you've got on
Yeah.
the right is not there as much on the left, but it's got to be there, hasn't it?
Sorry, say again.
That damage on the right, which Matey said was blood, it's not as bad on
Yes.
the left, but it's got to be there's got to be damage there because it's black, isn't it? So you've got to have damaged that lung as well, eh? Because the air came
Yes.
from somewhere, didn't it? All right, so now we've got two lungs that are leaking like sieves. Somebody talked about under pressure. Not yet, but that's going to happen if we put a tube down or we leave it down for very long. So looking at that throat, what's down that throat? Down to about your clavicle region, called an endotracheal tube. So we're highly likely to make that worse. But if I ventilate this patient, what's going to happen to my venous return? Thelma, since you've been so quick with the typing, you can help me here. What will happen to my venous return if I increase the pressure in the chest by ventilating them, do you think?
It will reduce it.
Reduce it or increase the pressure? Oh, decrease. Yep, you're quite right. Or reduce the venous return. You're quite right. So you can see how our resuscitation evolves. We can turn hemorrhagic shock into obstructive shock by what we've had to do to the system. The commonest way we produce obstructive shock is throwing a tube into someone because you're instantly decreasing their venous return. That's why people drop dead on the end of a needle when we ventilate PEs. Their right heart's barely coping now. We increase the intrathoracic pressure more, the right heart says enough, and they basically die an obstructive death. So when we look at all of this, the identification of a thoracic injury, these are all signs that help us, but we have to keep going back and back and back as it evolves. Part of trauma and part of what you're going to confront in a ward, day 2, day 3, day 4, is this evolution. Do you think that right lung is going to get better or worse over the next 48, 72 hours? It's going to get worse, isn't it? You got at least 10 days of misery here, and the left lung probably to follow. So we can predict from our table where we are, look at an X-ray, know what the apoptotic response will be, and predict this is going to get a hell of a lot worse than it gets better. All from that one chest X-ray and knowing now what our system will do. Because if our cardiac output is down and we give a lot of fluid to this, which is arguably what we're going to have to do, what do you think is going to happen to your lungs, which are already leaking like a sieve, if I give more fluid to it? It's going to get worse, isn't it? So we've got a system which, simply put up front, can be take patient, add water. I want you to start to realise we keep coming back and using the same system over and over and over again. When we say reevaluate as our system, this is what we reevaluate every time, the ABCs, because what we've done to keep them alive potentially makes them worse in other ways. Next slide.
Excuse me, would you be like repeating the X-ray regularly, or you just do one baseline?
Yeah.
Well, baseline,
It's-
well, to see what's going on.
It's a good question, Matey. I repeat it if something goes wrong.
Okay.
Okay, so if something's not doing what I think, would they get another X-ray in the morning? Yes, but in this patient, let's say this patient here, would I put chest tubes in that patient? Look, I may not if they're going to ICU where they're in a high visibility area. Would I, if I was flying them? Yes. Would I do a chest X-ray after putting chest drains in? Of course. If, however, they drop their stats in about 2 hours in my ICU, they'd get another chest X-ray, or would be just putting blind chest drains in and getting an X-ray anyway up front. So it's not as simple as would I do it regularly in 2 hours. It's I'll do it in the morning or sooner if I need. Does that make sense? One of the reasons, and you raise a very good question, one of the reasons for that is if we CT all these people, we find an enormous number of pneumothoraces that we never saw in plain chest X-ray, and they never actually come to harm. So a lot of these things you don't need. But here's one that's going to tell you a story. So what we've got here is a seatbelt injury. Have a look at what we've got here. Do you think a hoarse voice might worry us here? And if so, why? Why might this patient have a hoarse voice? Could be a laryngeal nerve palsy. Unlikely. It goes around the aorta. So no, but possible if we had coexistent thoracic dissection, but unusual. What about the neck there? Is there anything in the neck that, you know, has an air-filled thing? Starts with T and ends with trachea. Yeah, trachea. So here, if the seatbelt's too high, we get a hoarse voice, and we can get a tracheal injury. And larynx as well. It's probably a little bit low for that. To be honest, they're fairly rare. Hoarse voice is generally more often seen with burns. The tracheostomy, if you did here, would be awake, or we would do it. This would go to theatre for a fibre optic intubation. We'd have a look. However, how is this going to manifest as shock? What else worries us where that bruise is? Are there any big vessels there? Yeah. What ones are they, Makey? Jugular vein, someone's written, yeah. And behind that?
Oh, yes, that's right. The JVC, yeah.
Behind that, is there an artery? Carotid's a bit high, but it joins, it can't, yeah, subclavian. So we always worry, don't we, that here would be getting close to our sterno, wouldn't it? A manubrio or clavicle joining manubrium, joining sterno, that's sternoclavicular joint. Behind that is where our great vessels are. So this would worry us with that as well. Okay, next slide.
Sorry, would you be thinking like a heart injury?
Unlikely with just that. So we'll do heart injury separately, but suffice to say, heart injuries are incredibly common with trauma and incredibly irrelevant to treatment. Pretty much, you're going to get a tachycardia, you might get a bit of a stunned right ventricle, a mild troponin leak, and it usually means nothing. The only ones that really matter is a cardiac obstruction. If they really have, in non-penetrating trauma, a bad heart injury, they die pretty catastrophically at the scene. So for blunt trauma, cardiac, if we do the issues, cardiac's thing. Now, I think the next slide might have an X-ray somewhere. There we are. So Carolyn, you were talking about obstructive shock before. This is why you get obstructive shock with a tension pneumothorax. It's got nothing at all to do with the pneumothorax and the hypoxia. It's got everything to do with the lack of venous return, and hence we can't pump into the lung. Added to that, we therefore create a massive dead space if it came to that. But this is true obstructive shock. Likewise, as Marky asked, Makey or Marky? Sorry, Makey? Makey?
It's Marky, thank you.
Marky. So as Marky asked with the heart, if we were to stick or bruise our heart and bleed into our pericardium, we would get the same effect on a normal chest X-ray because the heart can't fill, cardiac tamponade. It would be a normal chest X-ray because we can't see around the heart. Both will give you obstructive shock. Okay, now in real life, that X-ray, they say you shouldn't see that X-ray. That's not true. You often see tensions. In real life, the way that I would deal with this patient is this patient would need to be ventilated. There's no way around that because you're not going to get near that chest without that. But you need two teams. The first person, or you need three teams, someone to actually judiciously give them enough sedation and paralysing agent. The second person to put the tube down and not ventilate them. The third to put a big hole in their left chest. And it doesn't matter where it is, it's just got to be big enough and more than 2/3 the size of the diameter of the trachea. Once that happens, you do not need a chest drain in this patient because it's now fully positively pressure ventilated. You will not get a sucking chest tube wound because you get a sucking wound because you breathe in negatively, then a big hole. And those of you who work in Australia will see these people come into ED with two big gills in their axilla. And the HEMS people just put their fingers in, they make a hole, put their fingers in and go tear, tear. And all they do is produce two big holes like that, no chest drain. It'll work because they're ventilated. So you'll see them increasingly coming in from the roadside with two big holes in their chest, ventilated. And that's what it's for. You don't need a chest tube if the hole's big enough because the air will get out. It won't suck in because we're not negatively pressure ventilating. Does that make sense, Marky? Sort of.
Kind of.
All right. Well, do you breathe in or out? So when you breathe in with negative pressure, don't you? Your diaphragm goes down, correct?
Yeah.
So if you had a hole in your chest or lung, you would suck air in through your chest wall, wouldn't you? Because it's another
Yes.
hole, isn't it? Now, when you tried to breathe out actively, if you had a hole in your lung, you close that hole so the air stays outside the lung, doesn't it?
Yeah.
Okay. Now, if we said, oh, you're really sick, we're going to put you on a ventilator breathes in positively. We blow air into you, don't we? Hence, as long as there's a hole in your chest, we're going to blow the air out of that hole, aren't we? It's not going to suck in, is it?
No.
You're no longer, yeah, and that's how it works with just two big holes. Okay, so you will often see these people coming into EDs when you're a resident and wondering why don't they have a chest drain. I was told you need a chest drain for trauma, which is indeed true, but once they're ventilated, a hole will do. Okay, so you'll see them come in with that. Next slide. Here, however, is our patient not ventilated, who has a sucking chest wound, breathing for themselves. We would put a 3-sided cover over that because we've got a drain. Therefore, when they breathe in, we stop the air going in. And when they breathe out, we let it come out either through the hole or through the chest tube. Doesn't matter. If the patient was actively or ventilated with, on a machine, that's what they'd come in with from HEMS. We would put a chest drain in a separate site and we would just stitch that up or leave it. It doesn't matter because they're positively pressure ventilated. So if someone's breathing themselves, that needs a one-way valve and it's just a sticky dressing. If it's not and they're ventilated, then we can leave it open because the air is going to just come out the whole time. Happy with that? Yep. All right.
You're
Next
not
slide.
worried about infection?
I don't care about infection, Makey. We'll keep them alive now. We can always come back and drain it later. That's tried to say, but in reality, these, I know of one that's been infected, one that's ended up needing a lung transplant, but at the scene, it's all you've got, it's what you do. So you're going for the greater good. This isn't pure and nice at the scene. This is ugly, and that's what you do. So sometimes you just put up with it. In general, they don't get infected. It's remarkable. They generally don't get infected. Next. The patient in this slide is not ventilated. That's yes. Well, I've used it, Daniela, for two purposes. One is to show you what we should do if they were not ventilated. This patient here is in that one, but we've left it open. So I'll put it in there for two reasons. One is to say what we do if they were not ventilated. The other, we can leave it open if they are. Everyone happy with that? Yep. All right. Yep. Okay, next. Okay, so flail chest. Never has so much been written about so little rubbish. A flail chest, for all you will read, is nothing more than a mush of lung underneath some broken ribs. That's it. The flail is irrelevant to you. All of the rubbish you read about paradoxical movement, etc., is a crock of rubbish as to their ventilation. What it tells you is if you've broken more than 2 ribs in more than 2 spots contiguously, is there a lot of force? Yes. What do you think the lung's like underneath? Bad. And that's what it's telling you. End of story. So the paradoxical movement you see is nothing more than an aha moment. This chest is bad. Okay? That's all it means. We are therefore not going to give it a lot of fluid to make it worse. We're going to give them adequate analgesia and enough oxygen. They're going to be a high oxygen, high work of breathing environment. But the actual flail is irrelevant to you. It just means they have a bad lung injury, which will get worse over days. And I will give you a great reason as to why we know that. You will, in your career, often see ribs taken to form skeleton or skeletal frameworks for various things. We often do it in kids for brains and kids for skulls. We'll knock out 2 or 3 ribs. Those kids go back to the ward and they go home the next day or the day after. They have a flail, don't they? We've taken out umpteen ribs, but we haven't damaged the lung. Hence, they breathe quite well. And they have incredible paradoxical movement. So the broken rib is nothing more than a marker of how much force you put into the chest. That's what it means in trauma. Nothing more than that. And all of the other rubbish about, oh, the air goes in and out the wrong way is nothing more than rubbish, and there are any number of papers to show it's garbage. They are just bad lung contusions that will get worse because you've damaged the rib cage and the lung underneath. That's all you need to know about that, and they'll get worse over time. Next. Massive hemothorax. Big whiteout on one side. As Markey found out, it can only be red cells, white cells, or water. And this doesn't look like pneumonia since we're talking about trauma. And if we're going to give that much fluid, generally go to both sides. So this is going to be a massive hemothorax because it fills a whole chest. More than 1,500 mils of blood, and it will present as hypovolemic shock because you've lost that much blood, and you will make it worse if we have to ventilate them because we're also stopping the venous return on someone who's already lost pretty much 30% of their blood volume into that side of their chest. So you can see when I started to talk about how our treatment potentially makes things worse comes to pass in this case. The treatment is drain it, but it's operative. So in our case, we can put a drain in, but they'll need to go to theatre in general. Next. This is what 50 mils of fluid will do, Carolyn. That is a fast scan. That is a heart. And around that heart, you can see at the top a black line. That is fluid in the pericardial space. Normally, you've got 20 to 50 mils of fluid in your pericardium. In a young person, if we put another 50 mils in, we will tamponade them. They will present classically with distended neck veins. That only works if that's all they've got. Of course, if they've got shock everywhere else, we may not see the neck veins. They require drainage. It's usually a fairly simple operation to drain it. The cause, however, can be far more complex to deal with. But draining them is not that difficult. Surgically, Athol will know more than I do, but you can either go under the chest or you can even just shove a drain in and buy a bit of space. The last one of these we had in our peripheral hospital, I managed to put a central line into that, pulled out 30 mils, and he got up to the to Gold Coast because Robina doesn't do trauma. He turned up to the wrong hospital. So you only have to pull out 20 or 30 mils. They will get better venous return, and then you buy time to go to theatre. Next slide. Resuscitative thoracotomy, you will see people do this. You as residents will see it. You need to know about it, but you're not going to do it. These are patients who were alive at the scene, died en route, and were stabbed. Pretty much in our environment, that's it. It is rarely indicated in blunt trauma, rarely. When penetrating trauma, it is done more frequently. In reality, you can't be deader than dead, so it's actually technically not that hard an approach. And a lot of general surgeons will have a go. It is almost universally fatal unless the stabbing is pure right side. So if we think about it, those of you who have Valentine's Day cards, the heart is not like your Valentine's Day heart. The right ventricle sits at the front. The left ventricle sits at the back. So if we stab someone into their right ventricle, it's a low pressure injury that's easily get toable because it's an anterior structure. So they're the ones with the low stabbing that can be operated on, and all they need is a circular as a stitch, and they will often do well. Blunt ones don't, and left-sided ones don't, because you've got to get through to the back and they go on bypass. You will see it. I put it there because they will come into ED when you're interns. You won't be a part. You'll be part of a trauma team and go, oh my God, why did they do this at the scene? And it will be that. It'll be a penetrating trauma, alive at the scene, extinguished en route, and someone's had a go. Next slide. These are the ones you will now see in your travels. Brachiobronchial injury tends to present early with massive pneumothoraces. We drain them. A simple pneumothorax, pretty much more than 20% gets drained. Pulmonary contusion is ubiquitous and will get worse over 4 to 7 days. That is the one in the ward that dies silently. Hemothorax, if you can see it, we think about draining it. You need to lose about 400 mils into a chest to be confident of seeing it. So it's a fair whack of blood. Blunt cardiac injury, I put an asterisk there. Nobody anywhere in the world as of 2023 has a consensus document to diagnose it. And the reason is, if we do troponins on these people, about 100% of everybody in a road vehicle accident who's wearing seatbelts will have a raised troponin. We don't know what the hell it means. It's an overly sensitive test that tells us not very much. What is of use there is who to admit, and basically anyone who's got ECG abnormalities or anybody who has a history of cardiac issues will be admitted. But if they're otherwise normal over about 6 hours, they're often sent home, and the data is very good for that. And that even includes fractured sternum with no underlying ECG changes. Traumatic aortic disruption is something that you will see far more of in your career than Athol and I ever have, simply because we did not have access to high-resolution pan scanning. The end of this lecture, the end of this series, I've got a whole thing on pan scan for trauma, but pretty much we used to say 90% of these people died at the scene and about 10% of the rest died every day thereafter. Now we know people have gone 30 or 40 years who have clearly had an aortic tear with trauma and have got through. We just didn't image it. So this is something you will see more of. By and large, the treatment is conservative until they go to theatre in a tertiary institution. Blunt esophageal rupture is as rare in trauma, unless someone has got a belly full of KFC, a belly full of alcohol, and vomits against a closed glottis after the car accident, and they get Borhave syndrome. But it's pretty rare in blunt trauma to rupture your esophagus. It's pretty well protected. Now, diaphragmatic injury is something that is common. It is invariably on the left side. It is invariably missed, and CT scan is notorious for missing it. The reason is the diaphragm has almost no blood, and particularly if they're ventilated, we move the diaphragm for them, don't we? So if it's had a tear and it's had a bit of momentum or something go through the tear, if we ventilate the chest, we often push it back. The reason this is important in your history of have they had significant trauma is the average time to diagnose this is 9 months. And they turn up with an incarcerated piece of omentum and or bowel through a hole in their diaphragm. So your history taken as a secondary survey in the ward alerts people to go looking for these oddities. If we see it acutely, it's always because the stomach is sitting up in the chest and the nasogastric tube or orogastric tube tends to be there. Next slide. So here's an example. Whoops. Go back one. Here's an example we can now talk about that can look at most of these things. So, ladies and gentlemen, let's look at this chest X-ray. Marky told us before that if it's white, it's got to be red cells, white cells, or water. So we'll say there's white on the right. So we're going to call that blood. So we've got at least some hemothorax, can't see much down the bottom base. So we've got pulmonary contusion at least. What else though there? And Marky, I'll start with you because you were so good with the other one. What else is sitting outside the lung on the right? There. What's that?
Oh,
Yeah,
it,
it's black. What shouldn't be black? Yep.
no, it shouldn't
You're
be.
right. Yeah.
So,
So black can only be air and a chest X-ray. That's all it can be. So should air be there?
no,
Yes or no? Okay,
No.
so we've got to now have a pulmonary contusion plus what else at least? We've got air in the, so what do we call air in the subcutaneous tissue? Yes, that's Thelma's right. But where must it have come from, Marky?
I don't know.
Well, is there an air-filled thing next to it that's got a lot of bruising on it already? The lung.
Okay.
So this would be subcutaneous emphysema. So we must have, mustn't we, a pneumothorax here, mustn't we?
Yeah.
Because we can't have it any other way. Okay, let's keep going. Who wants to help me since Thelma's been so helpful with texting? Thelma, what do you think about the rib cage on the right side?
If you look at the rib cage, there's clearly some fractures.
Good.
Yeah, so there's multiple fractures, I would say. Don't ask me which ribs because it's a bit of a mess.
Okay, now, is there a pneumothorax there or not, Thelma?
A pneumothorax.
Mm-hmm.
Definitely, yes.
Okay, I agree. Where and what's the obvious where is it obvious? And it's not the subcutaneous emphysema as well.
Okay, so it's more at the basal end of the right lung
Yes,
field.
why do you say that? I agree. Why do you say that? Well done.
Because obviously, you know, the black spots, you can't really see the lung markings as clearly. It's diffused by the white out.
Now,
Also,
see those two little diaphragm things? Is one flat and pushed down compared to the other? Have a look at
yeah,
the left and right
slightly,
diaphragm.
yeah, slightly.
Ah, so what might push that down?
Increased pressure.
That's black. Yeah, yeah. So when you said before to me tensioning, this
Yes.
one is tensioning.
And
And the
there's a
reason it's
trachea.
tensioning, ladies and gentlemen, is we're pushing down, aren't we, the dome of that right diaphragm. So this is beginning to tension. So here we have already, how are we going to manage this? Airway is probably okay. Breathing, we're going to have to optimize. And the way we're going to optimize breathing is going to be analgesia and a chest drain to let the lung come up and judicious fluid. Now, next up, what do you think about if I've done that to that lung? What do you think might be, do you think our heart may or may not be affected? Carolyn?
So it might be pushed over a bit because of
Pushed
the,
over a bit, yep. And how could we look around the heart? What other thing would we think about doing? We'll do this when we come to a series. So when we look at our initial things, this is why we do a fast scan and do a quick shine up from the Ziffy sternum straight up into the chest. We don't care about whether they've had an infarct. We're looking for, have they got a cardiac tamponade? So that's what we're looking at for that. And then for the secondary things, we're going to pan scan or CT the chest, and that's going to look at, particularly in this case, aorta, and then we also get trachea, bronchi, and esophagus. But this person has got compromise B, undoubtedly. A, I doubt, because we don't have a great deal of subcutaneous emphysema. And C, I would be astonished if we did not have a C problem, starting with a bit of blood on the right side of the chest, not much. There you've probably only got, 300-400 mils, but I would be wanting to rule out an aortic injury here, given we've crushed everything there in that chest. Now, we've also got our ribs fairly low down. Is there any organ living under the diaphragm that may contribute to a C problem here, Marky?
The liver.
Terrific. So again, our chest X-ray showing us we've got ribs there is leading us, if we were hypotense, there's not enough on that for bleeding alone. I'll be wanting to look into the abdomen as well as a hidden site, wouldn't I? Because those ribs have been awfully close to the liver, aren't they? So you can see how the chest X-ray gives us an enormous amount of information of what's there and then where to go look next. So when you asked me the chest X-ray, when would I do another one in a couple of hours? Here it would be after the chest drain's in. Here I'd put a chest drain in, probably just then do a pan scan because we can at my hospital easily. Otherwise you'd put a chest drain in and do a chest X-ray would be your next step. You'd do a fast scan of the abdomen. If you couldn't, you could do a DPL of the abdomen in areas that don't have access to a fast scan, and thereafter we could determine where to go. We'll deal with that when we come to our system, but you can start to then think about the ancillary tests we do and what order we do them and why. Just at this chest X-ray. Next slide, Athel. Okay, the downstream organs, ladies and gentlemen. Athel, what slide number is that, mate?
Where's the number?
Dunno. You should have them on the side.
I've got it blown up, so
Okay. Right. Okay. All right. Let's do some downstream fun.
I'll minimize
Let's
it.
look at the splenic circulation. That's okay. What are we up to about? So what time we got now, Athel?
It's 2048.
Righto. So we might, how about we call it quits there, ladies and gentlemen? Yep.
It's
that's
slide 68.
Okay, so we'll look at the downstream effects. So what we're going to do, Athel, just put up the big, just put that up and blow it up into, they can see all the slides. So if you go down the bottom and put, not slideshow, but go down to slideshow and go into the one that shows them all the slides. It should be on that. It's on PowerPoint, isn't it? I don't know how you go out of that.
No, it's not on PowerPoint. It's on
All
some
right.
other.
Okay, so when you guys look at this, that's slide 68. The next bit we're going to look at is the downstream effects and the injuries to all those organs as we move downstream, okay? Once we've done that, that is what we would do in an EMST course over the first day. We will then look at applying a system, and then we look at a patient and take a real patient through a real trip for the whole lot. Does that sound all right?
Greg, would you want me to get this, anyone who's on tonight, get them the whole slide deck?
Absolutely, yeah. Oh, yeah, absolutely.
Or is there
Yeah,
300?
no, that's fine.
300
Oh,
or
look,
something?
there's tons of, yeah, the slides are there. What I'm trying to do, because I don't know what you guys do and don't know, and what you've come from and to medicine, is to, it seems to me little point in telling you, take patient, add water for this injury, if some of you don't know a bit of underlying reason as to why this is what we're going to do. So for some of you, this is suck eggs. I get it. For some of you, it's, oh my God, I get it. So what I'm trying to do is walk you through in a number of ways. One is the physiology. Secondly is the organs and how they respond. And lastly, how we're going to put a system together and then take a real patient for you. So if we do it that way, by the time it comes up to your AMC exams, hopefully it will have taken you on a full journey. So that's the plan. All right, I'll see you in a fortnight, guys. That's all right?
Thank you.
Oh, Mikey, I saw you scratching the screen. Was that because I look old and blurry to you, was it?
No, I'm just on my phone. That's all. But
Oh,
thank you so
teasing.
much.
All right,
I'm
darling.
on-
Bye-bye. Bye-bye,
Bye.
everyone.
See you in 2 weeks. I'll get
Oh, I
those
didn't know.
things out.
Oh, Anne was there. I should have asked her a question. You were remarkably silent, Anne. Double questions next time for you. Is that fair? Mute, are you?
No questions from you, please.
All
Thank
right.
you
See
so
you
much.
guys.
Thank you. Bye.
I'll
Bye-bye.
get the slides out to you guys. Thanks, Greg.
Okay, mate.
I'll call you tomorrow.
Righto.
Okay, thanks. Bye.
Bye-bye.